So I do see a couple of people who have joined us before. So for those of you who are returning attendees, welcome back. For those of you who are new, hello, warm welcome to you. My name is Visa Gabrihana, and I'm the Public Relations Manager here at CIGC. This is our third webinar in the Ask the Experts series, and this is on revolutionizing GYN surgery, exploring innovative procedures. We launched this webinar session back in February with the intention of really exploring very important gynecological topics with an expert who's been in this industry for many, many years and have performed numerous procedures in this field. So we are really fortunate to have Dr. Danilyants here with us to provide this series. So the goal of today's session is really, if you can advance Dr. Danilyants to the next slide so that I can. So the goal of today's session is really, for the past two webinars, we focused on conditions. We talked about endometriosis, ovarian cysts, we talked about pelvic pain, and now we're shifting a little bit focus on treatment options, techniques that we can use to really address the issues. We are going to really specifically focus on what we are expert at here at CIGC. So we'll be providing insight into each technique, including the benefits and the risks of the methods, showcased really different visuals. Dr. Danilyants is going to use real life photos to demonstrate the techniques, as well as provide a background research on how effective these methods are. And so before we begin, I would go ahead and do a few housekeeping just to get us on point. These PowerPoint presentation and any resource that would be shared during this presentation will be emailed out to you in a follow-up in 24 to 48 hours. This is going to be an interactive section. We really love hearing and just going back and forth in terms of questions. So if you have any questions, you can go ahead and utilize the Q&A option to send in your question. It's never rude to send a question while even Dr. Danilyants is presenting. We actually have spots in this presentation where we're going to pause and take those questions and address them live. If we don't get to them during this webinar, we'll get to them and send you a response post the presentation. Okay, so if you don't see that option, the Q&A option, just hover at the very bottom of your screen and you should be able to see the Q&A option. If in any case you are kicked out of this presentation, like I said, we're expecting a lot of people, or you want to leave and come back and you're unable to join, I would encourage you to refer back to the email I sent this morning, and you can use either the call-in option or we'll also, like I said, we'll provide the recording, so we'll be able to send you if in any case technology fails. With that said, I'm going to go ahead and introduce our wonderful speaker, Dr. Danilyants. Dr. Danilyants is a board-certified gynecologist and fellowship-trained in minimally invasive surgery. She developed and perfected the dual portal GYN technique, as well as the LAM, advanced gynecological surgical technique, which she's going to talk about today, and has treated and has performed over 10,000 surgeries. Dr. Danilyants is considered an expert in her field, and we're really, like I said, privileged to have you here with us, Dr. D. I'm going to go ahead and pass the mic over to you so that you can get us started.
All right. Thank you so much. Thank you. So today we'll be talking about specific procedures that we do in our practice, and they are the LAM procedure, which is for fibroid removal, the dual port hysterectomy, which is for uterine removal, and then endometriosis excision. So I'll start with the LAM. So what is LAM? It stands for laparoscopically assisted abdominal myomectomy, which is a hybrid surgical procedure. It's to remove fibroids. So this is for women who are desiring to preserve the uterus for fertility and who have fibroids. The benefit of this procedure and what sets it apart from others is that it has no hospital stay, so it's completely outpatient, and it has a short recovery. it's really the best option for fibroid treatment, okay? Because we're completely removing fibroids. So if there are, let's say if there's a large fibroid or there are multiple fibroids that are preventing someone from getting pregnant or decreasing their chances from getting pregnant, this is going to be the best option to remove the fibroids. It also immediately improves the symptoms, right? As soon as you're removing the fibroids that are causing these symptoms, your symptoms improve. So these symptoms could be of frequent urination, or let's say your abdomen is big because the fibroids are large, or pelvic pain, or again, infertility, abnormal bleeding. So all of these symptoms are resolved as soon as the fibroids are removed. And then we're able to remove large fibroids, and we're able to remove multiple fibroids. We're also able to remove fibroids that are deep inside the uterus. Now, there are different types of myomectomies, right? So a general term myomectomy just means fibroid removal. So you can go about it in different ways. So the lamp procedure, and this is showing the incisions. So you have a small incision at the top aspect of the belly button, and then there's a second incision in the bikini line. So that lower incision, this is a ruler. The inches are at the bottom and the centimeters at the top. We typically say like about 4 to 5 centimeters, or about 2 inches or 1.5 inches. Compare that to open. So open myomectomy, or we call it abdominal myomectomy, typically requires like a C-section incision. So this is about 6 to 8 inches, depending on the size of fibroids and the size of the uterus. Sometimes those incisions have to go up and down, which is in this other photo. And this is someone who had very large uterus, obviously, or large fibroids, excuse me. And then robotic or laparoscopic. So with robotic, you have multiple incisions. Also note my mouse went away. Oh, here it is. Also note the position of the incisions. So the incisions, because of the robot, have to be positioned in the middle of the abdomen. So the top of the picture, the head would be at the top and the legs at the bottom. So with the lamp procedure, the incisions are sort of strategically placed so they're more cosmetic, right? The belly button incision is very small, so it heals, and it's very faint. And then the bottom incision is in the bikini line, whereas the robotic incisions are all in the middle of the abdomen. Now, we're comparing, again, different types of myomectomies, right? The lamp, which is the procedure that I'm talking about, versus robotic or conventional laparoscopic or abdominal myomectomy. So what's the major difference? Again, hospital stay. So for the lamp procedure, there's no hospital stay. We do these in an outpatient surgical facility, so the patient gets to go home the same day. The duration of the procedure, look at the robotic, up to 4 hours, and sometimes even longer, depending on the skill of the surgeon, depending on the number and location of the fibroids. And then look at the recovery for the open myomectomy. It's 6 to 8 weeks. So that's very long compared to about 2 weeks for the lamp procedure. Now, where do I get this information? We actually published a study, and this was published back in 2018. We had 1,300 patients. My mouse keeps going, okay. We had 1,300 patients. So all of these patients underwent a fibroid removal surgery or myomectomy at Holy Cross Hospital, which is located in Maryland. And this is not done by our practice. This is all of the myomectomies that were done between year 2011 and 2013. Some of them were lamp procedures, which we did, but then the rest of them were different procedures. Most of them were open myomectomies, because even today, with today's technology and extra training, most myomectomies are done via open approach, via big abdominal incision. So at Holy Cross Hospital, there are several laparoscopic surgeons, there are robotic surgeons, but yet still most of the myomectomies are being done open. So we took all of these myomectomies and we decided to compare the data, right? We looked at the blood loss, at how many fibroids were removed, how long the surgery was, what complications there were during surgery and after surgery, and wanted to compare the outcomes. And what we found is that the lamp procedure did so much better than other procedures. in terms of removal of fibroids, right? So patients always ask, well, can you take out, I have so many fibroids, or my fibroids are so large, can you do LAM procedure with this? Yes, you can. So during the study, we found that the LAM approach was actually able to remove more weight in terms of fibroids than even the open myomectomy. And look at the standard and robotic, very little, right? Because these procedures are limited, and I'll talk about why. Complications were lower compared to all the other types of myomectomies, right? Compared to standard, to robotic, and to abdominal. The abdominal myomectomies had the highest rate of post-operative complications, because anytime you have a big open surgery, there are things that come up. You're in a hospital, right, for several days. So you could get pneumonia or other hospital-acquired infections. There are issues with your sort of gastrointestinal function not coming back as quickly. So we call it an ileus. There can be issues with urination or infection again. So the bigger the incision, the more invasive the surgery, the more potential complications just based on the size of the incision. And then look at the operative time. The robotic myomectomy took the longest, right? Because again, it's the way the surgery is done robotically, you're limited as to how fast, how efficient the surgery can be. And with the LAM procedure, the average time was about 76 minutes. This is, again, comparing LAM to other myomectomy techniques. This is taking all the times, right? So look at the open and robotic myomectomy. The longest was 252 minutes. That's a very long time, all right, compared to 90 minutes of the LAM procedure. And the number of fibroids removed, 103 with the LAM versus only 13 with the robotic. So with the LAM procedure, you're able to remove more fibroids, larger fibroids, and in a shorter amount of time, again, with no hospital stay. Another important thing is that conversion to open surgery. So a lot of patients ask, what are my chances that you start doing a minimally invasive procedure, but then end up having to do an open incision? Well, if you're having a standard laparoscopic myomectomy, that risk is pretty high, right? 23%. And even with robotic, it's high. Open, obviously it's already open, so there's nothing to change there. But with the LAM, it's less than 1%. So this is just kind of when I said this is a hybrid procedure. So what I mean is what we're doing, we're making a small open incision. Remember that small incision in the bikini line. And we're combining it with laparoscopic techniques. So we're sort of taking positives from both, right? From open and laparoscopic, and we eliminate disadvantages. So what are the advantages of open surgery? Well, there's no limit on the size of the fibroids, right? There's no limit on the number and no limit on location. So you could have 100 fibroids or you can have 5 fibroids, but they're all really deep within the uterus. So with open surgery, you can take out any fibroid. The downside of open surgery is, of course, a large incision, which translates into longer recovery. So what we're doing, we're creating that very small open incision. So that gives you still short recovery, small incisions, but we're still able to do everything that a traditional open surgery can do. With robotic and laparoscopic, you're limited. Yes, your incisions are small. Yes, your recovery is short, but the problem is there's limit on the size of fibroids. So if you have numerous fibroids, it's not realistic, not feasible to do it laparoscopically or robotically. If you have very large fibroids, can't do it laparoscopically or robotically, it's too risky. And then the limit on location. So with robotic or laparoscopic surgery, because you don't have that open incision, you don't have the ability to feel the uterus. So the only fibroids that you can tell are there, the ones that are sort of protruding out of the uterus. So if you have a fibroid that's deep inside the uterus, you don't have the ability to feel for it, and so you don't have the ability to really remove it. And those deeper fibroids are actually the ones that typically cause heavy bleeding and issues with fertility. So when it comes to, for example, fertility doctors, they prefer that we do the LAM procedure. If they have a provider they can't do LAM, then they say, okay, we would rather you do it open, right, and get all the fibroids than do a robotic or a laparoscopic approach and not get the fibroids that we really care about. But with LAM, we don't have to compromise, right? We're still providing a minimally invasive surgery with shorter recovery and still accomplishing what would be accomplished with a big open cut. Now, the common question is, how do you take out large fibroids through small incision, right? And do you use a power morcellator? So we do not use a power morcellator. So what is a power morcellator? And somebody had asked that question in the chat. Power morcellator is a powered device that is used to break up fibroids into smaller pieces. It's inserted through one of the laparoscopic incisions, right? So that's why it's long. And there's a spinning blade that's powered that spins around like this. And you insert an instrument to grab the fibroid, and then the fibroid gets ground up through this shaft, and then it's removed through the other end. The risk with this is that, well, the downside, not only risk, but downside is that it takes quite a long time, right? Because you're only able to take out tiny, tiny pieces. So if you have a very large fibroid, literally an hour or more can be spent just, grinding up that big fibroid into smaller pieces. So that prolongs the duration of the surgery, prolongs the time that you're under anesthesia. The second issue is that small pieces, as this blade spins, small pieces can fly off into the abdomen, because this device is inserted inside the abdomen through one of the incisions. So if there is potential cancer in the uterus that was, undiagnosed, you can potentially be leaving pieces behind. So this device is no longer used by most physicians, by most providers, and some hospitals don't even stock it. Now, people that do use, the surgeons that do use this device, use it with a bag to try to contain the pieces. But again, the biggest disadvantage to me with this device is that it takes a really long time. With the LAM procedure, you don't need a power morcellator at all. And what you're doing is shown here. So here's that lower bikini incision. We insert this little plastic, we call it protractor or retractor. So it makes the opening round rather than a slit. So it makes things easier to see. And then what I'm doing is I'm bringing that fibroid up to the incision, right? So the fibroid has already been detached from the uterus, and now I'm bringing it up to the incision, and I'm cutting it at the skin level on the outside. I'm not cutting it inside the pelvis. And I'm holding on to the piece that I'm cutting. So you end up with very large pieces. The piece can be as large as the incision, right, in diameter. And so you avoid small pieces. And this is also much faster, right, because you're taking out large chunks of the fibroid. And again, everything is contained. There's no need for the bag for this method, and it's fast. Now, can LAM really remove all my fibroids? Yes. Oh, I forgot the towel. Hold on, let me grab it.
In the meantime, if you guys have any questions, please go ahead and type them in the chat box. And we have allocated time to pause and address them. So any questions, please go ahead and plug it in that Q&A box.
Okay, sorry. Anyway, I wanted to just, to be dramatic. So this is the blue towel that we use in the operating room to place the specimens to take a picture. So you can see the size of the towel. The ruler here is a 6-inch ruler for both. The picture on the right is just more up close because there are fewer fibroids, and on the left it's just zoomed out. But you can see it's basically the entire width of the towel, and really almost the whole towel itself is covered by fibroids. Some are very tiny, And this is the large, one big large fibroid that's been removed in segments versus the small fibroids are removed as a whole. So these actually 2 surgeries were done on the same day. You can see this was just recent. So the point is that you can remove as many fibroids as you would do with a big open incision. We're just making a small incision. And what that allows, it allows the patient to recover much faster. Conversion to open, I had mentioned it earlier, but this is actually from the study. So look at the green line here at the bottom is the standard laparoscopic for large, greater than 750 grams. So that's large fibroids. So the larger your fibroids are, the higher chance that even if your physician starts it robotically or laparoscopically, that they're going to have to convert to open. With the lamb, that conversion stays very low. Okay, so that's the advantage. Now, what about embolization? Let's say you say, I don't want to have surgery, even if you're going to do it lamb or robotic, I just don't want to have surgery at all. And my doctor gave me UFE or uterine fibroid embolization as another option. Now, what you have to keep in mind is that it's not recommended for patients desiring fertility. Although if you go to for a consult to a interventional radiologist to discuss UFE, they will say that there are, plenty of documented cases of pregnancy. But that's different than saying it's not recommended. So because there are 2 things. First of all, the fibroids are not actually removed. So if you have fibroids within the uterus that are decreasing your chances of getting pregnant or continuing a healthy pregnancy, you're not changing anything. The fibroids are still there. So embolization is not going to make these fibroids disappear. Another thing very important to keep in mind is that embolization can affect ovarian function, okay? The rate is about 17%. So that's pretty significant, especially we do see a lot of patients in their late 30s or even early 40s trying to conceive. So the last thing you want to do is further decrease the ovarian function that's already at a natural decline. UFE does not improve bulk symptoms. So if you're having frequent urination, lower back pain, so any symptoms that are created from the fact the fibroids are large or bulky, that's not going to improve, okay? And does not work for very large fibroids. I was talking to a patient the other day from out of state. I can't remember where she was from, but she had embolization done last year and it did absolutely nothing to her fibroids because her fibroids are very, very big. So it was a complete waste, of time and money and, surgery and recovery. So even with UFE, although it's, sort of minimally invasive or non-invasive, there's still recovery. And most importantly, you have to be a good candidate for it because again, if you have large fibroids, or if you're trying to get pregnant, this procedure is not for you. And this is just a sort of demonstration of how. So let's say you have these fibroids. So these are the fibroids, the yellow things, the pink is the uterus. So, and the brown here is the inside of the uterus. So some of these fibroids are bulging into the uterus. So this patient would have all the symptoms, abnormal bleeding, but then they're also going to have back pain. Here's the spine. There's a fibroid here. Here's the bladder. They're going to have frequent urination and their belly is going to protrude because the uterus is large. If they have a UFE, so here's a fibroid that's turned black because you've blocked some of the blood supply. The other 2 didn't get affected at all. So this patient is still going to continue to have all the bulk symptoms, right? And they're continuing to have abnormal bleeding. So nothing's really happened. The only difference is that this black fibroid is not going to get any bigger. So it will forever stay this size, or maybe it will reduce just a little bit. But their issue with getting pregnant is still the same. After a lamb or after any myomectomy, once you've removed the fibroids, you have the uterus that's back to normal. And it doesn't have the fibroids in it anymore. And there are risks with any surgery, right? So there's potential complications like infection. So even with the least invasive, in the best hands, there are always potential complications, but you want to sort of optimize your chances, right? You want to choose the procedure that's going to actually remove the fibroids and not just kind of stop them from getting larger. All right, so
we have a lot of questions.
Yeah.
So let's tackle them.
Yeah.
So the first one is, what is the largest fibroids that has been removed via this procedure?
What is the largest fibroid via this procedure? I mean, there's no limit. I think the weight, the top weight, well, let me see, let me go back. As far as I remember, it was about 6 or 7 pounds, but I think, oh, here it is. Okay, so this was actually, so this is the top here. So it's almost 7,000 grams. So 7,000 grams is going to be, you know, over 15 pounds. So yeah, so that's, but there's really no limit. I mean, you can have one fibroid that's really, really heavy and it's really impressive, but sometimes actually, you know, numerous fibroids are much more difficult of a surgery to do than taking out one even very large one. So, I mean, but
often it also looks like a pregnancy. You can see, like, the larger it is, it can look like a pregnancy.
Yeah, exactly.
Can you get the LAM procedure after getting a myomectomy, an open myomectomy?
Yes. Yeah. And again, you know, these sometimes the repeat surgeries are more difficult, right? Because there's going to be scar tissue from prior surgery. But, you know, with fibroids, unfortunately, they come back. So even if you remove every single fibroid, always tell patients, yes, the risk of recurrence is very high. And typically the younger you are, the more, you know, probability that you're going to have recurrent fibroids and have to have another surgery again. That's why we typically say, if you're not interested in getting pregnant, doing any type of myomectomy, LAM or any other, is probably not the best option because the fibroids come back. And I have a lot of patients that come back to me after I've done LAM procedure on them before with recurrent fibroids saying, oh, you know, I wish I didn't do this last time. I wish I had just had a hysterectomy. Or maybe it's someone who we did a myomectomy on and they were able to get pregnant and now years have gone by and now they're ready to do something more definitive.
And I think that's also why it's important that, like, during the consultation or the discussion process with the patient, understanding what's important to them is something that our doctors also do, is just understanding what matters to you, whether it is having children in the future or not wanting that. The procedures you select could really depend on that.
Yeah.
Go ahead, doctor.
Yep, no, keep going.
So we have a question on that line. After a LAM procedure, is C-section, required for future childbirth?
Yes. So the requirement for a C-section is not dependent on how the fibroids were removed in terms of incisions, right? So even if I make 5 incisions versus one big one or the LAM or whatever, it depends on where in the uterus the fibroids were removed. If we have to cut into the uterine muscle and remove fibroids, we have to then put that muscle back together, right? So reconstruct the uterus. If a patient goes through labor, which means just that muscle contracting, it can rupture, the uterus can rupture, right? So this violent, very strong contractions can pull that tissue apart where it's been sutured before. So that's the risk. And it doesn't matter how many years have gone by, even, you know, if it had been done last year or 10 years ago, there's still a risk of rupture and it's significant. And it's, you know, it's extremely dangerous. So that's why anyone who's had a myomectomy, where again, we've cut into the uterus to remove the fibroids, they should absolutely have a C-section.
I know we have a lot of these questions coming in, so I try to get through as much of them as possible. I have UFE procedure a few years ago. Can the LAM procedure remove all of my fibroids that have calcified as well?
Yes. The question is yes. a lot of patients that have had UFE procedure, we do recommend to have the uterus removed rather than a myomectomy, because the uterus have already been sort of damaged by the UFE, unless this patient is really trying to get pregnant. So I've had seen younger patients who've had the UFE because they thought that the procedure would not impact their fertility. So in those cases, yes, we would do the lamb. If it's someone who did the UFE because they weren't, they have no interest in fertility, they would recommend that they do a partial hysterectomy, because overall risks there are lower with the partial than the lamb, because the blood supply to the uterus has been compromised by the UFE, and the healing is just going to be not as good. Yeah.
Okay, let's take a few more questions, and then you can proceed with your presentation. I will come back to the rest of them. One last two questions is, can repeat surgery on the uterus to remove fibroids weaken the uterus and increase the risk of urine rupture during pregnancy? And what sort of scarring is to be expected?
Yeah, so anytime you do surgery on the uterus, again, it doesn't matter if you have one, big open incision or small open incision, there's a potential for weakening the uterine muscle, just like what I talked about with C-sections. But even, let's say the labor has not happened, if there are numerous fibroids that were removed from the uterus is going to be weaker. Typically, if it's a few fibroids, there's still good, healthy uterine tissue there, that risk is going to be very low, versus someone who's had, 100 fibroids removed from the uterus, that risk of uterine rupture, even just as the pregnancy grows, is going to be high. And sometimes we tell patients, after myomectomy, that they should not try to get pregnant. That's very rare, but that does happen. Because again, the uterus has been so damaged by all these fibroids sitting in the uterus and growing for many, many years, that there's no way to sort of reverse that process, right? All we can do is remove the uterus and stitch it back together. But the damage has already been done.
Great. And I know you guys have a lot of questions about fibroids, prevention, treatment, options. I want to just plug in here that next month's program is actually really solely going to focus on fibroids. So you'll have an opportunity to have like an in-depth dive into that next month. So how about we proceed with the presentation, and then we'll come back to more questions, Dr. D. Thank you.
Yeah. All right. Now the next thing I want to talk about is the type of hysterectomy that we do. So again, just like with myomectomy, hysterectomy means we're removing the uterus, right? And there are many ways of doing it. One way of doing it is through a big open incision. And then there are different variations of kind of laparoscopic or minimally invasive hysterectomies where small incisions are made. So robotic is one of them. What we do is a dual port hysterectomy, which is using just 2 small incisions. But in order to accomplish this surgery with small incisions and with few small incisions, we do use very advanced techniques like retroperitoneal dissection, we call it RPD. And what it does, it minimizes the risk during the surgery, allows us to use only few incisions, and also makes the surgery very efficient. So it cuts down on the surgical time. Another term that I will use kind of throughout is the LRH, which is laparoscopic retroperitoneal hysterectomy, which is because it's using, again, this advanced technique. So it allows us to identify very important structures like the ureter, which is a tube that goes from the kidney to the bladder, and there's one on each side, and different major blood vessels, and it helps, again, reduce the risk during the surgery. Now, what about, again, comparing it to standard laparoscopic, to robotic, to vaginal hysterectomy, right? That's when the uterus is removed completely through the vagina, and then open, traditional abdominal or open procedure. So with conventional laparoscopic hysterectomy, there are typically multiple incisions. With robotic, as I showed for the myomectomy, the incisions are placed across the belly, so they're less sort of strategically placed. So as far as cosmesis, you end up with just more obvious incisions on the abdomen. There's also more pain. So with the dual port, there are fewer incision. Again, because we're using special techniques inside, there's less bleeding, shorter operative time, fewer complications, and it all translates into shorter recovery. And this is, as well as the myomectomy, this is all outpatient, right? So no hospital stay. So this is, again, just kind of little cartoon showing different incisions. Now, as far as, as far as the research, so we did a similar study that we did for the myomectomy, but now this was comparing hysterectomies. This was published in 2019 in the Journal of Obstetrics and Gynecology Research. We had 2,600 patients. So again, these are all the patients that had any type of minimally invasive hysterectomy between year 2011 and 2013 at Holy Cross Hospital in Maryland. And the dual port was 756 patients. And then there were all other types of hysterectomies. We did not count abdominal. We just took and compared to all the minimally invasive hysterectomies. And this is the outcomes. Fewer incisions, right? So with dual port, typically we use only 2 incisions. In some cases, a third one was required, but majority of patients had only 2 versus with robotic, right? Most patients had between 4 and 5 incisions. Shorter operative time. Look at the 62 minutes. So, right, just a little bit over an hour versus the other ones required more time. So this means that you're more time under anesthesia. Complications. The dual port, which is the yellow, had the lowest complication rates for intraoperative and postoperative complications. The robotic had the largest, highest complication rates for postoperative complications. Larger uterine size. So that means, so the bigger fibroids you have, right, the larger your uterus is going to be, the heavier. This is based on weight. So the heaviest uterus that was removed was a little bit over 9,000 grams. So that's going to be multiplied by 2.2. So times 2 is 18. So it's about 20 pounds, right? So that's the heaviest versus through all the other. Open, even open was low. But these are all the minimally invasive ones. So much smaller uteruses were taken out versus the retroperitoneal hysterectomy. Is my uterus too big for LRH? No. So this was the 20-pound uterus. So this is 2 massive basins filled with uterine tissue. But this is just to demonstrate. And, you know, are we going to see a patient with a uterus that size every day? No. But we do see quite a few patients like that. And, you know, one reason is somebody is telling the patient, watch and wait. Another reason is that the patient is getting, you know, the options of minimally invasive surgery is not given to the patient. And honestly, with the uterus that size, there are going to be very few surgeons in the country that are able to do it minimally invasively. So kind of the longer you wait, right, the options keep getting smaller and smaller. But we do definitely do large uteruses minimally invasively. Now, what is removed during the hysterectomy? Just, I know that we're kind of talking about techniques rather than specifics, but this is just to kind of differentiate. You can have a hysterectomy where you're removing the uterus and the cervix and the fallopian tubes, which are out here, versus only uterus and tubes, not the cervix. So a lot of times we will do a supracervical hysterectomy. So again, it's still retroperitoneal hysterectomy, where we do a supracervical. So we're preserving the cervix. So in that case, that second lower incision is slightly bigger to get the uterus out. Or maybe everything is removed. So this will depend on individual patient, what their issue is, what their symptoms are, and what they're looking to do. So all of these 3 are possible with the dual port. Now, again, comparing it to embolization, as I mentioned, if you're looking for your abdominal girth to decrease because you have very large fibroids, you're not going to get that with embolization, right? So if I take this uterus and I do embolization, it's going to look exactly this way. Nothing will change. So I do not recommend embolization if you have large fibroids. So yeah, so that's the bottom line. Any questions? I'm kind of now trying to go through it quickly because I realize we're like.
Yes, we have how about we do 3 questions at a time, and then if we have time left over at the very end, we can just go back. And so we have a question here. How do you fix a leaking uterus endometrial fluid, which prevents implantation after open lamb?
Yeah. So sometimes it's leaking. So yeah, there's always fluid in the uterine cavity. That's difficult. That's difficult to fix. Sometimes it's an issue with the uterine lining. So for some reason there's always fluid in the cavity, and so they can't do IVF. That's not extremely common, but typically if there is no scar tissue or anything that can be sort of visually fixed, typically it's not something that can be fixed. Yeah.
Thank you. Is natural pregnancy still possible with a mild dilation of the distal end of one tube, but still normal free spillage of the contract from this tube while the other tube is completely blocked?
I mean, yes, it's possible. So anytime, although this is not specific to fibroids, anytime you have an issue with the fallopian tube, even if it's open, there's an increased risk of ectopic pregnancy, of tubal pregnancy, even if you're doing IVF. So typically, a tube that's dilated, fertility doctors don't like, leaving it in place because it could potentially impact implantation. So I would say, it's hard to say. If it's a completely functional tube and visually it's normal, then pregnancy is possible. But if it's, if one tube is blocked and the other is mildly dilated, you have to wonder, there's probably the same process is happening, right? And affecting both tubes in a different way. But overall, that certainly lowers the chance of successful pregnancy.
One last one. What is the advantage of keeping the cervix after hysterectomy?
Yeah, so sometimes that's a good question. Sometimes we like to keep the cervix to preserve the integrity of the pelvic floor. Sometimes, taking out the cervix, even when we do it laparoscopically, can create a shorter vaginal length, especially in women who already have a shortened vagina. So by keeping the cervix, that kind of helps preserve the vaginal length, and really you're not changing anything anatomically when you keep the cervix. Also, the healing of the top of the vagina can sometimes be delayed for various reasons. And so by keeping the cervix, you kind of avoid that issue altogether.
Great. All right. I'm going to go ahead and let you continue with your presentation. We'll get to the rest of them at the end.
Sounds good. Sounds good. All right. Let me close this. Okay. Oh no, it kind of went up. Okay, so, all right. So last, endometriosis excision, and then I don't want to sort of minimize the topic of endometriosis, and I'm sure we'll be, doing many more sort of endometriosis specific webinars. But so endometriosis, right, when abnormal tissue grows outside of the uterus, and it's very important when doing endometriosis surgery that it's done by a endometriosis specialist, because you're actually, by completely removing or excising endometriosis and using, again, very specialized techniques like retroperitoneal dissection or ureterolysis, which is basically when you're able to separate the ureter from the abnormal tissue that frequently implants near the ureter, you're lowering your risk of recurrence. So you're lowering your risk of needing to have yet another surgery. The incisions are small, so there's no robot. A lot of endometriosis sort of specialists use the robot, which is really not necessary. It's kind of what they've been trained to do and what they feel comfortable doing, but you really do not have to use the robot to remove to successfully remove endometriosis. And a lot of times we do it with just using, again, 2 small incisions. The recovery is much shorter because you're using fewer incisions and you're using smaller ports or smaller incisions. So there's less pain, less trauma to the abdominal wall. But the complete excision, that's key here. We always look for endometriosis during laparoscopy. So that's another thing. Endometriosis is extremely, extremely common. So if you look at statistics, there's like 1 in 9 or 1 in 10. So I think these statistics are definitely lower than reality, because the problem is endometriosis cannot be definitively diagnosed without laparoscopy, right? We can suspect it, but we really don't know if it's there or not. Unlike fibroids, which are seen on imaging, endometriosis is not seen on imaging. So we always look for endometriosis during laparoscopy. And most of the time we find endometriosis, even when we're not doing it for endometriosis purposes. So for example, for fibroid removal surgery, and I'll show you the slide, I think. No, sorry. Here. So this is a study to look at endometriosis and fibroids in patients undergoing LAM. So we took the patients that were undergoing LAM procedure, right, for fibroid removal. And we said, how many of those patients actually also have endometriosis? And we found that it was 45.4% endometriosis confirmed histologically. So it means we took a biopsy of that tissue that we thought was endometriosis, send it to the lab, and the lab said, yes, this is endometriosis. So basically half the patients who have fibroids and were having fibroids removed had the LAM, had the endometriosis. And you're not going to get that by having open myomectomy. When you have open myomectomy, those small endometriosis lesions are going to be missed. If you're having a myomectomy done by a non-specialist, a lot of the endometriosis is going to be missed. So it's really important, even if you're not having sort of classic endometriosis symptoms, or even if you're having, so many issues with fibroids, you're not even thinking of endometriosis, it's important to consider endometriosis at the time of the surgery, because it can cause pain, it can cause infertility. So it really is important to address it. Second issue is proper excision, right? So this is another study that we did. We looked at endometriosis patients that underwent excision. This is for advanced stage 3 and 4 endometriosis, not just mild endometriosis. And we followed them for 7 years, and the reoperation rate was only 3%. So that's why, using the retroperitoneal approach with complete excision of endometriosis is important. Also, what's important is follow-up after the surgery, because we do follow our endometriosis patients very closely. And advice also on medical treatment after the surgery. So it's a combination of surgery. So surgery is the key, but then following the patients and really kind of monitoring and changing different treatments depending on their symptoms. Okay. All right, and this is, again, this is actually what we did, and we presented this at a meeting in 2020. This was World Congress and Controversies in Obstetrics, Gynecology, and Infertility, because when we looked at literature to see what the coexistence of myomectomy, of endometriosis and myomectomy was, it was 12 to 26%, which is still high, but what we found was actually higher. So again, a lot of times surgeons are not looking for endometriosis when they're taking out fibroids. And it's important to do both, right? Because really our goal is to address any pathology, right? Anything that's abnormal there, we want to address. So, all right. Now, let me look through the questions here. We talked about cervix.
Yeah, we stopped right at Natalie.
Yeah. Yeah. So that's a good question about insurance. So which insurance carriers have you been most successful with coverage of these procedures, especially out-of-state patients? So unless you have some insurance plan that will only cover in-state surgeries, and once in a while we come across that, and so that for that, no matter what surgery you have, how common or uncommon, if you go out of state, your insurance says no. So unless you have something like that, there is no issues with insurance coverage. So we do accept commercial insurances. And so, yeah, if you have insurance, then your insurance will cover LAM procedure because it's under a myomectomy. So it's not, insurance companies don't really care about very specific, detailed techniques that a surgeon uses. So it goes under a code that's for either for laparoscopic or for open when we do the LAM procedure, and it's covered by insurance. So there is no problem with coverage. Let's see. Can a very thin line of scar tissue prevent implantation? Yes, it can. So typically we recommend removing that. As far as financial cost, what is the cost out of pocket if insurance is not covering? It will depend on what the procedure is needed, what we expect in terms of timing, and we certainly have financial counselors that can look at your situation and they can give you an estimate. So that's not an issue. And remember, we're not using a hospital, so your out-of-pocket cost is going to be substantially lower than if you did it in a hospital. All right. Let's see. Okay. Yeah. So as far as blood loss, what is the best way to preserve your blood during the surgery? So great question. So typically patients that have fibroids, or a lot of patients will have what's called anemia, which is low blood count due to the fact that they have very heavy bleeding. And so they're losing blood faster than their body can make new blood cells. So if you have a normal blood count, typically excessive bleeding is not a huge concern during a myomectomy, especially for medium-sized fibroids. For very, very large fibroids, what we do is we use what's called a cell saver, which is a machine that, hospitals have this too, that sucks up the blood that's being lost during the surgery if there is excessive bleeding, and then it gets processed and we can give it back to you through the IV right away, immediately. All right, so that really avoids an issue of having to be admitted to the hospital and having to get a blood bank blood. If you're to answer the question, there is no need to preserve your blood ahead of time if you have normal blood count. If you have a low blood count, you really can't donate blood, even if you're doing it for yourself, because you're already very, very low. So that's going to drop you even lower. So you can't do that. That's not an option. So your option at that point would be if your blood count is so low that we cannot do safely surgery, then you would have to get treatments to increase your blood count. So either iron infusions or potentially even a blood transfusion right before the surgery. That we have done that before for women who have severely low blood count. All right. Is getting fibroids genetic? They're very, very common, right? So 80% of women have fibroids. So it's certainly wouldn't be unusual for multiple family members to have fibroids. All right, so if I had open surgery to remove fibroids, but they couldn't take them all out, can I still have the LAM procedure? So yes, so we can do LAM after the open myomectomy if that, that's required. All right, how do I find other surgeons that, they can do this? Yeah, so, I mean, that's tough, right? So if you have, as I mentioned, if you don't have out-of-state coverage, that's going to be tough because I don't know, what state you're in and whether there are, any surgeons in that state who can do minimally invasive myomectomy, right, at all. Not even LAM, what about, so it's hard. I think sometimes path of least resistance would be to wait for open enrollment and then get coverage that's more broad and you're able to have options, but it is very difficult. Sometimes with some insurance plans, you can sort of write a letter to tell them there are no specialists, right, in your state that can do this procedure. And very, very rarely, the insurance will make an exception, but I would say that's extremely unlikely and rare. I don't know. Yeah, so I did not go into menopause after UFE. Does this procedure change the ovary function overall? So most patients don't go into menopause after UFE, which is good because you're not meant to go into menopause after UFE. So the UFE only is meant to block the blood flow to the fibroids. It's not supposed to block the blood flow to the ovaries, but that's one of the risks. So sometimes because you're dealing with blood supply, blood vessels, and those blood vessels kind of course between the uterus and the ovaries. So inadvertently, some of the blood flow can be blocked to the ovaries, which can lead to decline in ovarian function. But hopefully that does not happen if you do have a UFE, but about 17% of the time it does. So what sort of scarring is expected with, whether it's myomectomy or hysterectomy? Overall, hysterectomy surgeries cause less scarring than a myomectomy would, because it's much less invasive. You're doing much less, right? So even if we're dealing with a large uterus with many fibroids, and we're just removing the uterus, leaving the cervix and the ovaries, it's much less invasive. We're doing much less tissue injury, creating tissue injury to remove this, versus if we're doing a myomectomy, because with myomectomy, we have to cut into the uterus and to remove each individual fibroid and then repair the uterus back together. So there's much more healing involved after a myomectomy, and scarring forms from healing. So the more healing that has to take place, the more potential scar tissue they can form. All right, and okay, I think we did what caught. Okay.
Yeah, there are a few ones that came in
Okay.
towards can endometriosis return after the excision? If yes, can the patient prevent or control its return through diet?
Sorry, say that again. Sorry, I was
Can endometriosis return after excision? If yes, can a patient prevent or control its return through diet?
So yes, endometriosis can return, right? Because so just like fibroids, it's a estrogen-dependent condition, disease. So fibroids can return after we take them out. Endometriosis can return after we take them out. Yes, just like with fibroids, a more effective removal, right? So if you remove all the fibroids, they're going to be slower. New ones are going to be slower at growing versus if you didn't remove all of them. Endometriosis is the same thing. If you were effective, if your surgery was effective in removing all of the endometriosis, then the time between surgeries is going to be longer, right? Or symptoms. Diet, to some extent. So with endometriosis, again, because it's estrogen dependent, and because we know that fat cells produce hormones that are then converted into estrogen. So women who are overweight are going to have higher estrogen, body estrogen, circulating estrogens. And so potentially the risk of endometriosis or other estrogen dependent conditions are going to be higher, even in someone who's postmenopausal. So in someone whose ovaries are no longer producing any sort of significant amount of estrogen, can still have recurrent endometriosis if they're overweight. And then can LAM procedure be utilized for endometriosis? So the LAM is specifically for fibroids because we're creating that open lower incision. If we're just dealing with endometriosis, small implants, that lower, bigger incision is really not necessary. However, sometimes we do this little open incision for women who have ovarian endometriosis cysts. So those incisions are going to be very sort of similar. We don't call it LAM because we're not taking out any fibroids, but the incisions are going to be similar in the sense because we can actually pull the ovary through the incision, remove the endometriosis cyst, if it's a large cyst, or maybe it's not an endometriosis, maybe it's a different type of cyst, and then repair the ovary by hand, and then kind of return back to the abdomen. So that's a great procedure because it minimizes the injury to the ovarian tissue and helps really repairing the ovary to improve, fertility, ovarian function.
There's one more question here about someone who's going through a menopause and doesn't want to get hysterectomy, but if they do the LAM procedure, what is the risk of fibroids coming back? Like in relation to the age also, does age has?
Yeah. So typically, I always recommend, or I don't recommend actually, the LAM procedure for women who are either in menopause or perimenopausal, or just not, whose uterus is not going to be utilized in terms of pregnancy. Because again, it's a more invasive procedure. There's more recovery, there's more pain, and there's more potential complications. If the fibroids are small and that patient has already gone through menopause, then maybe they won't need anything at all. And, sometimes I see patients that come in and they say, oh, I have fibroids. Do I need to do anything? And I look at imaging and I say, I really don't think you need to, because you really don't have any symptoms. And it's really, we're just going to go in and do surgery just kind of for the sake of doing surgery, right? Those fibroids aren't, if they're calcified, if they're already hard, they're not getting bigger, there's really no point of doing anything at all. If they're very large, you're going to run into the same risks as with any patient with large fibroids. And then we have to ask ourselves, are the risks going to outweigh the benefits? So what is the benefit of taking out fibroids and preserving the uterus? Because you're preserving the uterus for fertility. So if you're not doing that for fertility, then all of a sudden the risks are going to be outweighing the benefits, because there's really, the only benefit would be just to keep the uterus because the patient feels that they need the uterus, not necessarily for fertility, but just they want to keep the uterus. And, I like to weigh pros and cons. Have I ever done a myomectomy on a patient who's not interested in fertility? Yes, but it's very select patients in whom I believe we're really not increasing the risk by choosing one over the other, right? So because it's my goal to do the procedure that's going to have potentially the least amount of complications. If I think I'm doing something, sort of not intentionally, but consciously choosing, right, or recommending a procedure that I know is going to be more risky, that's not the right thing to do. And then
we are right at the top of the hour. There is one last question about how does the procedure affect sexual functioning? Maybe we can talk about that before we wrap up.
Yeah. I'm assuming we're talking about a hysterectomy here. So with the hysterectomy, again, if we're preserving the cervix and we're preserving the ovaries, you're not changing anything hormonally and you're not changing anything structurally, right? And as long as, those two things are true, there is no change in sexual function. And a lot of women who choose to have their uterus removed either have, large fibroids, pelvic pain, endometriosis, adenomyosis that causes a lot of pain with sex. So if anything, because we're taking out a structure that has a problem, right? We're not doing a healthy uterus hysterectomy. By taking out a structure that has a problem, typically sexual function improves because there's less pain and discomfort.
Perfect. Thank you so much, Dr. Danilyant. And I know everyone had just some excellent questions. Thank you for being so engaging, everyone. We love these open forums where we can really answer your questions while also providing information. And I can't thank you enough for your time, Dr. Danilyant.
Yeah.
So just a few, I'm sorry, yeah.
It was great. Go ahead.
No, just a few housekeepings before we wrap up. As I've mentioned at the beginning of this presentation, we'll share these resources in a follow-up email, and the recording of this, as well as the first two sessions in this series, are going to be available on our YouTube channel. I'm going to ask you in the follow-up email, I usually send a link to an evaluation form. Please take a moment. It will take you less than 3 minutes to complete it, but it really helps us improve our future programming. So I encourage you to take a few moments to share your feedbacks with us. That would be great. As a reminder, our next webinar is going to be next month, and June is actually Fibroids Awareness Month. So we're going to really focus on providing as much information about fibroids, treatments, symptoms, and all that background information on the condition. So mark your calendar. I will share the dates for our program in the follow-up. And if you need consultation, we are here. There is a link that I would share in the follow-up email. You can just directly go into that link and fill out a form, and someone from our practice will get back to you as soon as possible. But if you need consultation, or someone you know that you think someone you know would also benefit from this information and can use our help and services, we encourage you to go ahead and share that information as well. So with that said, I hope you have a great day and a beautiful week. And we're going to go ahead and wrap it up right now. Have a good one, everyone. Oh, go ahead. Yeah.
For consultation, we do phone consults as well. So if you're out of state and you just need another opinion, or whatever, if you have questions about the surgery that you're going to have back home, and you just want another opinion to see whether it's something that we also recommend or there are other options, feel free to reach out. Again, we do phone consultations, so you don't have to come in person.
Good point. And I'll include that information in the phone information in the follow-up. You'll get the follow-up in about an hour. So thank you, everyone. We appreciate you. Thank you, Dr. D.
Yeah,
have a good one.
Bye.